So my name's John Kinroswright. I'm a hospitalist physician, so I'm internal medicine trained, and then I just do exclusively inpatient medicine. In the US, it's almost exclusively a disease of smokers or long-term asthmatics who eventually transition into a COPD type. The mechanism that's causing the damage in your lungs is basically chronic inflammation. So, the smoke inhalation, your lungs like, this is bad. And so it does what your body does when it has stuff that's bad. It sends an inflammatory response. And so that chronic inflammation, the inflammatory cells, while good for fighting infection and short-term thing, not good to be happening 24/7 every day. You lose your elasticity, your ability to push air out quickly, and then you're always inflamed, so you're producing mucus, and that's why you have the chronic cough and the increased mucus production. Respiratory infections are probably the most common complication you're going to see. So, you're more susceptible to viral infections as well as pneumonias. I guess COPD exacerbations could be considered a complication where you have an acute worsening of your COPD and either need to go to the ER or be hospitalized. Longer term complications, you can experience heart failure from the increased pressure that the heart has to use to pump through the damaged lungs. There's also some correlation with hypertension and some memory impairment. The cardinal symptoms of COPD are shortness of breath, most noticeable with activity. That's when people tend to notice it first. Chronic cough, and then increased sputum production. So people have a junky cough. If you're having a chronic cough, which is like a daily cough for more than 3 months, or you're noticing that you're getting shorter breath with activity, those are times to go see your primary care. Because it might not be COPD, you could have asthma or something. Even if you're not a smoker, those symptoms should be something you should seek medical attention for. COPD is diagnosed very specifically with pulmonary function tests. So the two numbers that we look for most often on that are your forced vital capacity, so how much air you can breathe out after taking a full inhalation, and then the ratio of that with how much air you can breathe out in 1 second. The best way to prevent COPD, since it's almost predominantly a disease of smokers, is to quit smoking or to not ever start smoking. You're never going to get back to prime lung function before you started smoking or had whatever exposure started you down the path of COPD, but you can get some back, so you can have improved lung function. The first thing to do is stop the progression of COPD. So, in the vast majority of cases, that's either quitting smoking. So if you haven't quit smoking, that is the goal number 1, 2, and 3. Until you've quit smoking, the COPD is going to continue to progress. The second goal is symptom management. So that's when we use our bronchodilators, our inhalers. So, when you're doing something and you're getting short of breath, you can have something to alleviate that. So the albuterol inhalers probably are most common. And then we have pulmonary rehab, which we've, have good results with. So you can actually restore some lung function with that. I treat a lot of COPD, both here and in my other hospitals that I work in. It's something that I'm very comfortable with. We have all the facilities here you would need to be treated. We do BiPAP here. Obviously, we do the steroids and the nebulizers. We have respiratory therapy here, which is one of the mainstays of COPD treatment. And if worst case scenario comes to it, we also can intubate patients here, and we have ICU beds that we can manage that at. So, you're gonna get all the care at Brookings Hospital that you can get at a bigger facility.